I take the honor to call Malaraj ma'am on stage. She's the founder secretary of IH Tamil Nadu chapter. She's a managing council member of IH. She's a joint treasurer of FOGCE, past secretary of IMS Chennai chapter. She has undergone her advanced endoscopic surgery from Strasbourg in France and China Medical University. She's a FOGCE or ICOG recognized training center for endoscopy. She is trained in aesthetic gynecology under Dr. Red Allensard at California. She is an accredited menopausal practitioner. She has received the Best Doctor Award from Tamil Nadu MGR University. She has lot of laurels. She is actually known as the endoscopic surgeon for any kind of myomectomy. It can be laparoscopy, hysteroscopy or anything. She's renowned laparoscopic specialist in India and abroad also. She's best video award in IAGE in 2018, operating faculty in various conferences. She received recently the St. Dr. Satya Paul Award for Excellence in Minimal Invasive Surgery in 2022. She's authored many chapters in various textbooks and currently she's the managing director of Firm Hospitals. Over to you, ma'am.
So thank you so much, madam, for the warm introduction. Respected chairpersons and my dear friends, at the outset I would like to thank Team FOGCE for this invitation and the opportunity. So it is a very phenomenal effort by Dr. Aruna. Hats off to you. Of course, now the topic given to me is a very interesting topic, especially when we are dealing with fertility. And this is going to be a comprehensive guide on hysteroscopic myomectomy. So looking at fibroids and hysteroscopic myomectomy, so when we do any procedure, first we should understand the pathology. Whether it is going to be a laparoscopic myomectomy or a hysteroscopic myomectomy, we should know what we are going to treat and what would be the outcome. So to understand that, we all should know that myoma, they are actually developing from the smooth muscle tissues and also from the fibroblast. So currently there's lots of light have been thrown on the developmental origin of the fibroids, and it has been found that the immature cells of the myometrium, they are stimulated by the upgrading of the steroid receptors. So they play a very major role. The estrogen and the progesterone receptors play a very major role in the development of the fibroid. And apart from that, there is an increased aromatase activity in the fibroids, which is mainly responsible for the growth of the fibroids. So if you see, it is only the solitary fibroids which grow faster compared to that of the multiple fibroids. So that is why we see huge fibroids not producing any symptoms and growing even up to 32-34 weeks. So when it comes to hysteroscopic myomectomy, the most important factor is that how we prepare the patient. So right from the diagnostic to counseling, we need to pay attention. And the most important thing is we need to evaluate this patient based on the history. The most important thing is whether she's come to us for infertility or for AUB. These are the two symptoms the fibroids can produce. Because our treatment is going to vary if it is going to be an infertile patient and if it is going to be an AUB patient. So for infertility, we need to make sure we take all the precautions not to damage the basalis of the endometrium, because these are the ones which are going to implant the embryo, and we do not want any kind of an Asherman's developing in this uterine cavity. So we need to take a thorough history of that, and next comes the bimanual pelvic examination, because it is not just the submucosal myoma which you are going to treat. You also have other various types of myomas, like the intramural myomas and the subserosal myomas, and subjecting a patient to a procedure, we need to make sure we tackle all of them at a single sitting, just not remove only the submucosal myoma and come out. So bimanual pelvic examination will help us to understand whether there are any other myomas in that particular patient, and of course a thorough blood workup. So most of these would be anemic, so we have to correct them hemodynamically and then take them up for surgery and other associated factors like thyroid, as we all know. The most important thing in this is the transvaginal ultrasound. So that is the gold standard for diagnosing the submucosal myoma with the availability of the 3D. It is a very, very good modality where we are able to visualize the entire myoma and plan our treatment protocol. Because with TVS we are able to assess what exactly would be the mode of approach for these myomas. We need to grade them as to how much they are in the cavity, how much they are occupying the myometrium, how much would be the extension of the base of the myoma. All these are very important for us to plan our surgery. And the next important modality is the MRI. Of course, TVS 3D is the best, but if you have an option and if the patient is affordable, nothing like an MRI which will thoroughly map and give you what exactly are the fibroids and where are they and the concomitant other types of myomas present in that particular patient. So once we get our women with a submucosal myoma, the most important thing is how are you going to grade these myomas. For this we need to understand the classifications. Various classifications have been put forward. We have the Wamstringer's classification, which was the first classification which was introduced, but this will just tell us generally whether it is type 0, type 1 or the type 2 myomas. So when we are doing a hysteroscopic procedure, we are mainly going to tackle the type 0 and the type 1. Of course, in certain cases of type 2, we can still do a hysteroscopic myomectomy. But this had a pitfall because when you have this kind of a classification, we will not be able to proceed and stage the surgical planning, whether what kind of a surgery we need to offer these patients, whether it should going to be a single sitting, double sitting or whatever. So in such a scenario, they were looking for another kind of a classification, which is a Lasmus classification, which is very essential when you are planning your surgery. So this will clearly tell us about the size of size of the myoma, the location of the myoma, the topography of the myoma, the involvement of the myometrium, and how much would be the base of the myoma, so that we'll have a clear picture as to how we are going to plan the procedure. So if the myoma is less than 2 centimeters, then it gets a scoring of about 0, and if it is more than 2 to 5, then it scores goes up like 1, and more than 5 it is 2, and above that the scores keep going higher and higher. And again, the topography also plays a very major role, because where exactly the fibroid is located is what the surgical simplicity occurs. So if the myoma is going to be present in the lower half of the uterus, it is a lot more simpler compared to the one present on the lateral wall and on the fundus. So the scoring varies based on where exactly is the myoma located. Then how much of the myometrial involvement does this for myoma occupies? So whether it is going to take less than 1/3 of the myometrium, or it is going to take 1/3 to 2/3 of the myometrium, or more than 2/3. So if it is going to be more than 2/3, then we need to decide whether we are going to tackle this particular myoma hysteroscopically itself, or we are going to combine a laparoscopy or do a hysteroscopy in 2 sittings. So these are the things which will add up to our decision making during surgery. The next would be the penetrations. How much of the myometrium is being penetrated by this myoma, whether it is less than 50%, more than 50%, or it is just superficial. So based on that, we are going to grade. And the lateral wall involvement. So all other fibroids are in fact scoring only 0. It is only the lateral wall myomas which are little bit challenging and tricky, so they score +1. So you add up all these parameters and you get a score. So once you get a score of about 0 to 4, then it becomes a low risk procedure where anybody can do the hysteroscopic myomectomy with a basic skill. But if the score is between 5 to 6, then it needs little more of an effort. So you need to have the expertise to do this particular submucosal myoma, and you have to be very, very proficient in doing this particular procedure. But if the score is going to be more than 6, then of course it is a complex procedure. So unless and until you are an expert, it is better not to touch these myomas, or you may have to also combine it with a laparoscopic procedures. So that is where our classification plays a very vital role in the management of the submucosal myoma. So apart from this, we also need the classification so that all of us have a same language to talk, especially when you are going to do certain kind of a study or a research work. We have to have the same kind of a grading of this myoma, otherwise it becomes, you know, like what may be 0, maybe 1 for another person, so and that can be variability. So that is the reason why we need these kind of a classification. And the most important thing in this classification is that the angle of view. So while you introduce the telescope, how exactly you're going to view this myoma plays a very, very important point for us to grade these type of myoma, because most of the times when you have a very good distension, what happens is because of the distensions, the small little myomas can disappear. So this you will see that while you are withdrawing your scope outside, these will again pop up. So always it is a good practice while you are doing a hysteroscopic myomectomy, in between just lower the pressure, don't have to remove the scope. The removal of the scope should be avoided as much as possible. So just lower the pressure and see whether there are any fibroids which are popping up. So these are called the disappearing signs. So that needs to be kept in mind while you are doing a hysteroscopic myomectomy for this submucosal myomas. Okay, so now the most important thing, having known about the pre-operative evaluation, do you really need any kind of a pre-operative preparation for these patients? So suppressive therapy is what some people are looking at. So especially when you have a huge myoma, then maybe you can give a GnRH analogs to suppress the size of the myoma and plan for a surgery. Ideally speaking, we do not believe in giving any kind of a suppressive treatment for these myomas. GnRH analogs only if she is very anemic and she is getting prepared for surgery, maybe you can put them on GnRH analogs. Or if you really feel that if the fibroid is more than 5 or 6 centimeters, you need some kind of a suppression, then you can give them GnRH analogs. The basic advantage of giving these suppressive therapy like GnRH analogs is that you can do them at any kind of any time of the menstrual cycle. You don't have to do it in the proliferative phase because it keeps the endometrium very thin and you are able to do the procedure without much bleeding. And another major advantage is that it causes suppression of the hypothalamic pituitary axis, and as a result the chance of fluid overload would also be very less. So the risk of water intoxication, glycine intoxication, everything would be less when you prepare them with GnRH analogs, but still keep your fingers crossed and always be cautious. The next thing is whether you really need to dilate the cervix before introducing the scope, whether we need to give any kind of a mesoprostol. There are various school of thought. Of course, some believe in giving mesoprostol. Dr. Aruna was saying that they give mesoprostol, but in my practice, I do not give any mesoprostol. So I basically feel it is better to have a rigid cervix and dilate the cervix if needed. That would be much better than having a soft cervix with mesoprostol, which would cause lacerations and sometimes even perforation. So the most important aspect what one needs to keep in mind while doing this procedure is that the best way to enter is by a vaginoscopy method. So I always practice a vaginoscopy method because once you hold on to the cervix with the tenaculum and then introduce the scope, there will be so much of rigidity and you will not be able to get the proper angle. So let nature take its course, let the fluid give you the passage, just hold on to the introitus, distend the vagina nicely, have a look at the entire vagina and the cervix and then enter. So the water will take you beautifully inside and you can get into the cavity. It is much better than dilating it with mesoprostol. So these are the basic advantages when you do a procedure with GnRH analog. Of course, it reduces water absorption as I mentioned, and of course your surgical time, because obviously the bleeding is going to be less. So how can you be successful in your particular procedure of hysteroscopic myomectomy? The most important aspect, as I mentioned, 90% is all because how you prepare the patient. You evaluate the patient, prepare the patient and take them up for surgery. Most of your problems are solved. The larger myomas, if they are more than 4 centimeters, the most important thing is you have to sit and counsel the patient, talk to her over the table as to there can be a chance that you may have to take her as a 2 sitting procedures, because if the surgery is going to get prolonged, we may have to stop and do it in the second procedures. But invariably, most of the times now we are able to complete most of these 4 centimeters easily without any issues. And anything more than that, if it is like 5 or 6 centimeters, it is a good advice to combine it with laparoscopy, wherein you can just open the endometrial cavity and remove this fibroid, like how you are doing a laparoscopic myomectomy. So if it is less than 4 centimeters, then of course hysteroscopy is the treatment of choice. So as the fibroid increases, we all know the volume also increases. So you have lots of fragmented tissues lying inside the cavity. What we need to keep in mind is, even you have so much of tissues inside the cavity, do not keep pulling your scope outside to retrieve these tissues. Always make sure that you try to remove the scope as less as possible outside, because the more you remove the scope, the more chance of air entry and more chance of air embolism. So it is mandatory not to remove the scope too often. So this is okay, so as I mentioned, it is the proper pre-operative evaluation which is going to be a success, a full outcome or not, based on how you are going to prepare the patient. So having known all of that, we should also know when not to do this hysteroscopic myomectomy. So when you are not properly evaluated the patient, of course if you are not having the proper expertise, and also we are not able to understand the fluid management. The crux in hysteroscopic myomectomy is that you have to manage the fluids very well. So the complications are more with hysteroscopic procedure than in laparoscopic procedure, because in laparoscopy you have a very good area to work in, and you have a beautiful distensions, and you are able to do all the procedure comfortably. But in hysteroscopic myomectomy, you are working in a very rigid and a closed environment, so the chances of your embolism is very, very high. So we need to keep that in mind and work there. So we need to understand the fluid mechanism, when to stop, and what kind of a fluid media we need to use and when. And of course, when there is any kind of an infection, we are not going to do any of these procedure. And when the penetration of the myoma is too much into the myometrium, and of course, it is a better, and you should see how much is the thickness of the myoma free margin. So that is most important, because that will help us to assess whether there is any incidence or chance of perforation in that particular case. So, and also when you are not going to have a good distension of the uterus. A good distension will help us to do the procedure comfortably without a frequent removal of the scope. So that is why I said better not to dilate this, keep any kind of a mesoprostol. It is always better to tackle a tight cervix rather than an over distended cervix. And also when you have a poor intraoperative visualization, as when there is kind of a bleeding. So general principles when it comes to hysteroscopic myomectomy, the most important aspect for a successful outcome is that we need to be very clear with the indications and the contraindications, and also excellent preoperative evaluations and the knowledge about the number, the size, the depth, the location, which means the Lasmer's classification. We need to be thorough, and also we need to have a good coordinations and then detailed understanding of the fluid management, and also ultimately it is skill and also judgment as to when to really stop and posture for the second setting. So how do we determine the depth of the myometrial involvement? So we need to make sure whether we are going to perforate this particular uterus or not. So, and we need to be very cautious, for which we can do even a saline infusion sonogram. Of course, a 3D ultrasound is going to help us to find out the myoma free margin, and also the MRI can also help us to find out how much of the myometrium is free from the fibroid. So we need to have at least a minimum of about 5 millimeters, so that we do not perforate that particular uterus, because these are all infertile patients. We do not want any complications even if she gets pregnant. So how are we going to tackle these myomas? We can do either an enucleation, or you can do a slicing, or you can even, the latest current one is a mechanical morcellation, that is tissue retrieval system. So the technique of excellence in hysteroscopic myomectomy is mainly enucleation of the intramural portion of the fibroid, mobilizing it, mobilizing the fibroid and also separating it from the wall, and finally dealing with the fragmentation by removing these tissues. So we have two major techniques: the enucleation technique, which was described by Mason in 1995, and the Lasmer's technique in 2001. So both these techniques, they do have the basics of enucleations, but Mason's is that he uses a cold loop. He tries to avoid, he just separates the myoma by a cold loop without using much of a cautery. So, or he reaches just the plane by slicing the myoma close to the myometrium. So, we should understand myoma has these myomas, the submucosal also have a pseudocapsule. Like how the intramural ones, we give so much of importance in laparoscopic myomectomy, stating that we preserve the pseudocapsule and do the procedure intracapsular myomectomy because the pseudocapsule are helpful for healing of the wound of the myometrium. The same principle applies even to the submucosal myoma. The submucosal myoma pseudocapsule also have nerve bundles and the growth factors which are essential for the healing of the endometrium. So our procedure has to be again preservation of the pseudocapsule in case of the submucosal myoma. So you have the two techniques which could achieve this principle and which is comfortable in your hands. Just please follow it. The next would be the Lasmer's classifications, where you have to enucleate the myoma, and this is again to incise the endometrium and the surrounding submucosal myoma to reach the pseudocapsule, and mobilization of the myoma. So you can either go laterally or you can come from above downwards and enucleate these myomas, and then finally remove them after the procedure by just gently curating them out. So this is a case of a submucosal myoma. So here you can see that we have entered into the cavity, and you have a large one coming from the lateral walls. So these myomas generally you see, I basically use only monopolar. So glycine would be my distension medium. I am very comfortable because we all belong still to the old school of thought that it has a better precision, and if you are very quick surgeon, nothing like glycine, because the precision is really better and it works much faster compared to that of any other bipolar energy source also. So you have to, the most important thing is our technique as to how we are going to do. We use a loop electrode wherein you have to just keep slicing them right from above downwards. Always the movement of the loop should be from fundus to the cervix and not from the cervix to the fundus. But then towards the end, sometimes the base of the myoma, we can also take it from below upwards, but you need the expertise and you should have a good control over the resector scope. So you can see that the entire myoma gets shaved off, and we should know where exactly is the endometrium and where exactly is this myoma. So because the most important thing is that we have to make sure that we remove only the myoma and not the surrounding endometrium, and these are the two things: don't damage the surrounding endometrium, don't go and penetrate deep into the myometrium. So these factors should be kept in mind, and we gently keep slicing these myomas. And how do you identify which is the end point, how much of the myoma we have removed and whether we have removed them completely. So the moment you see some kind of a bleeding or you see a pinkish color tissue, then you know that is an end point and we have to be done with the surgery. So you can see that the entire resection of the myoma is being done without removing the scope. The more frequently you keep removing the scope in and out, there is a chance for air embolism, because all the venous channels are all open and you may have complications. So just keep scoring them and you can remove these myomas. So when you have multiple myomas, you have the anterior one, you have the posterior one, which is the myoma that we are going to remove first? So that we need to understand. So in such a situation, it is always better to do the posterior one, because once you remove these posterior ones and then tackle the anterior one, it is much easier, because as you keep scoring over the anterior aspect of the uterus, all the fragments are going to come and get deposited in the posterior aspect. So as a result, for you to do the posterior myoma would be a challenge. So in a situation when you have multiple myomas, say 2 or 3, you do the one which is below, then you do anteriorly, and then you do the laterally. Laterally are more challenging compared to the anterior and the posterior ones. So finally when you are done, and then you have to remove these chips at the end of the procedure. So these fibroids, which is the one which attracts more attention, is the one which have multiple fibroids, because we have more raw areas and one at the opposing walls. That is, if you have anterior and posterior, they have more chance of adhesions compared to that of the one in the anterior and the lateral wall. So finally, at the end of the procedure, we should have a panoramic view like this and see that the entire endometrial cavity is clean and uniform without any other bulge, and you can make sure that your procedure is complete. So in that manner, these women will not have any problem. You allow the basalis of the endometrium to regenerate for a couple of months with OCP or whatever adhesion barrier you're using, and they will be able to get pregnant quickly. So this is again, as I mentioned, it is only a simple vaginoscopy method where you can enter. So there will be a resistance at the level of the internal os. You have to angulate your light cable in such a manner, just rotate it, because your internal os is going to be circular and your telescope tip is going to be oval. So you have to just angulate your light cable and negotiate and get inside the internal os. Once you do that, then you can see this fibroids. You have a small baby fibroid sitting there. Just scrape that off, and then you can tackle the bigger one which is sitting on top. So again, as I mentioned, you have to take it from above downwards, keep scoring on these fibroids which are a lot more simpler, and then you can see that you'll keep getting chunks like this. And this glycine is the media which I'm using. And the most important thing is, when it comes to fluid, how much is the deficit? So if you're going to use glycine, your fluid deficit should not go more than 1500. But if you're going to use normal saline, you can go up to the limit of about 2500. So you have a fairly advantageous margin when you have a normal saline. So that is why people are preferring the normal saline. But glycine, if you are able to follow the principle, there is nothing to be feared about. But you should always make sure that while you're doing hysteroscopy, the patient should always be flat. Most of the time we combine it with laparoscope. So for laparoscope, the patient will be in the Trendelenburg position, and now you have to correct the position, because we need to make sure your heart should be always at the level of the uterus. The heart should not be below the level of the uterus. So when you're giving a Trendelenburg position, the heart is going below the level of the uterus, and that is why you are having a fluid overload and you are having complications. Always the eye of the patient should be at the eye of the surgeon if you're sitting and doing the scope. Like how you say the umbilicus of the surgeon should be at the level of the umbilicus of the patient in a laparoscope. So these are the faint things we have to keep, and always have a look at the parotid angle to visualize the parotid sign. So will give us a clue as to whether this lady is going to go in for any kind of a fluid overload. You should have a vigilant anesthetist who should be well aware of all these problems, and if they know that you're crossing, they should alert, and also they will give you a Lasix. So these are the small basic tips that we need to follow while you're doing a hysteroscopic myomectomy. So you can see that the entire myoma has been scraped off, and we have come up to the base of the myoma, and almost the entire procedure is complete. Sometimes if they are going little deep inside, you can just stop using the energy source and just scoop it out with this resectoscope, and you can see that give little bit of massage on the uterus, and these small little ones which are sitting inside can also pop out. So these are the basic principle of hysteroscopic myomectomy. And we have to make sure that the entire myoma is removed from the cavity at the end of the procedure, and also make sure that there are no debris left behind, and your procedure would be complete. So slicing technique is what I showed you now. This based on progressive cutting of all the submucosal part and maintaining the fragmentation of the intramural portion. And also you have to make sure that you do not damage the endometrium, whatever I have mentioned, and then avoid any thermal damage to the surrounding endometrium. So this is again a case of this is a vaginoscopy method. So this particular case was almost a 4 to 5 centimeter myoma. So I had injected vasopressin onto the fibroid. So how you inject vasopressin laparoscopically? The same way, using a oocyte retrieval needle, you can introduce the oocyte retrieval needle through the operating sheath and inject vasopressin in the same dilution like what we use for laparoscopy. The same 10 units in 100 ml, but they will not require much, maybe 5 to 10 ml is all that is needed. So you can inject, can you see that how it is, the fibroid becomes nice and white once you inject the vasopressin. So even little bit of bleeding will not be there, and it makes the procedure very quick, because once you inject vasopressin, the fibroid becomes soft. So you can just score the fibroid off very easily. So this is in certain cases I inject vasopressin and do this procedure, and you will also not damage the endometrium. So this is a oocyte retrieval needle I have been using. So I inject it at the base of the myoma. So like how in laparoscopy we do, the same way I do it hysteroscopically, inject it into the base, and then you can see the myoma entirely turning white and pale, and you have a nice beautiful pink endometrium in the surrounding area. So you can just score these fibroids. So in this way you can see that the resectoscope is now being introduced, the same procedure is now being done. And how do you identify false passage also, you should keep it in mind. So once you know, like you are seeing some whorled appearance, the circular fibers, that means you are not in the right passage. Always withdraw the scope, align yourself properly and get into the right plane. So once you get into the cavity, you can just keep scoring it. So these were all degenerated myomas. So you can see the change in color, how much of degeneration this myoma have gone through, and you can just keep scoring all of this. So I'll forward it a little bit. So you can see that the entire myoma will be resected, and then finally you will have a very pink endometrium. So that should be our endpoint. Our endpoint should be always a pink endometrium and not a charred endometrium. So if you want to give her a good fertility outcome. So just keep scoring it, and you can see that the entire myoma would be resected completely. So you don't have to go in for 2 sittings, you can just complete the entire procedure in a single sitting, because patients are not going to be happy if you tell them you come back, I have the procedure is incomplete, you come back, I will do it the next time. Okay, so the whole thing is, so this is a slicing technique, the schematic representation. So this is again, here you can see that the cold loop excision, where the little intramural portion of the myoma, so without any energy source, using the Collins knife, you can just dig the myoma a little bit. That is releasing all that fibers surrounding the pseudocapsule, so the myoma pops up. And you can, bring that little myoma, which is little buried inside the myometrium, without damaging the myometrium. So we do not want to use any kind of an energy source in the myometrium, because that myometrium becomes weak, and then there will be chance of perforation when she gets pregnant and rupture. So technique of resection, of course, long loop is what, always try to take good chunk of tissue with each movement, and try to come from above downwards. So these are a few things that we need to keep in mind. And of course, this is how it is, like a hand should go up. When you have a posterior myoma, hand should go up, so you'll have a better chunk of tissue taken off. Okay, so this is again a myoma where you can just, when you have a small little myoma near the cornu, try not to use any kind of a resectoscope or energy source, because we are not going to damage the cornua. Okay, so in these myomas, a simple scissor is all that is needed. So cold cutting is what we need to do. Just take a scissor and just cut it at the base of the myoma. You can see that the entire myoma will pop out. So you will not damage the cornua, and also these will get pregnant very soon. Of course, they will have other concomitant fibroids, so we have dealing with all of that. So slicing technique is what I have been showing you. The principles you have seen, how you have to take the loops, and of course how to retrieve the tissues. As I mentioned, do not keep removing your scope on and off to pull out the fragmented tissues. Always make sure at the end of the procedure you remove all of these. And this is again another one which is coming from the lateral wall. So just forward it a little bit. So always have a look at the ostia. So you have to make sure you have a good look at the ostia, so that you do not go and damage them. And you can see that, so this is again a slicing technique where the entire myoma is being sliced off. These are real huge ones where you can do them in a single sitting. So this is coming from the lateral wall. So this is the back scoring. Generally I said no, you have to go from fundus to the cervix, but in certain situation you can go from below upwards, but you need to have good control and you should be comfortable in doing this procedure. So at the end of the procedure, you go to the base of the myoma and you can see that the entire myoma would be released and you have a very clean endometrial cavity at the end of the procedure. So the disadvantage, of course, any procedure has its own pitfalls. The flip side of this procedure would be sometimes you can anticipate bleeding. So for which I have a solution. We can inject vasopressin into the myoma and you can make sure that you are having a clean bloodless field at the time of procedure. And of course the fluid overload we need to keep in mind. The risk of perforation also we need to keep it in mind, because we need to know when exactly we need to stop, how much is the myometrium which is free from the myoma, and also frequent interruption of the surgery to remove the fragments is also a problem. So try to, as much as possible, to avoid removing the scope too often. So current setting, of course, we keep the current setting at 60 to 120 watts for cutting, and for coagulation at 40 to 60. You can increase it depending upon your requirement. So the speed of movement of your loop also determine the action of the whether you are going to have a cutting or a coagulation effect. So if you are going to move the loops faster, you will have more of a cutting, but coagulation will be less, while it is the opposite when you do it slowly. So apart from the shaving and enucleation, you have the latest one, which is the tissue retrieval system. So these tissue retrieval system have not been called as morcellators because the word morcellator have been condemned. So morcellators are going out of the market because of the issues which came up. So to overcome all that, the name has been modified as tissue retrieval system. So it is just a hysteroscopic morcellator, a fancy name given to this. Okay. So morcellators, of course, have expanded. So basic advantage of these morcellators are that you do not require any energy source. So just with normal saline, it just morcellates the fibroids and you are able to do the procedure. And the basic advantage here is that because there is no damage to the endometrium because of the absence of the energy source, it is a very good modality for infertility patients. So you have these morcellators which can be used when you have multiple myomas, because with multiple myomas, when you use energy source, the chances of adhesions are very high. So you can just, nibble off all these myoma with the morcellator and you can see that the entire endometrium gets free. So these are the morcellators which just nibbles off the myomas, and you can do the procedure comfortably without worrying about the adhesion formations and without the problem of perforations and any kind of an issue occurring at the time of surgery or post surgery. So morcellators are a good bet, and you can also do this in various other scenarios. So even for a small simple ones like this, which is only just like a polyp, which is a myomatous polyp, you can also use a morcellator. The basic advantage is that it makes it very, very quick, and also you don't have to worry about the fragments of tissues which are lying inside the endometrial cavity, unlike your resection where you have to keep removing the fragments. Here the tissues are all nibbled off and it is getting sucked up. But then of course you also do have an opportunity to biopsy these samples, because you can collect it from the sleeve which is present outside in the suction apparatus. So you finish it and then you can have a very clean cavity at the end of the procedure. So these are the current ones which are found to be useful. So how do you get started as a beginner when you start doing a hysteroscopic procedure? First, make sure that you do a proper evaluation, choose the right patients, and then planning of the procedure. Start with just small myomas. And if you're going to do an OP outpatient surgery, it is always advisable to do with these small ones. So when exactly we need to say, okay, enough is enough, I'm going to now do this procedure, only the second sitting. So when you have a huge myoma, when you feel that there is a fluid deficit is going more than 1,500 in a glycine and 2,500 in a normal saline patient, then that is the time when you call it off and then move on to the, allow her to come back for the second sitting. So, and if you are going to take quite a lot of time, so we need to move on. So in case of multiple myoma, large myoma, it is always a better, you can do it as a double sitting, or you can combine it with the laparoscopy and combine both the procedures and finish it. So when exactly you need to get the help of laparoscope, when you have a plethora of fibroids, or when you have the entire myoma occupying the entire endometrial cavity, and you are not going to, do a endometrial ablation. So when you want to do this procedure, you will end up charring the entire endometrium. So you will do an endometrial ablation rather than, doing any good to her. And she will come back with another problem of uterine Heineke-Asherman syndrome. You would have corrected her fibroid, you would have given her another issue of Asherman. So especially in a case like this. So this particular lady, she presented to me with almost 15 myomas. So 15 submucosal myomas and 3 intramural myomas. She was from Canada, where they put the scope and they saw these fibroids and they sent her off. So she came back to me. Looking at the report, I told her we have to do a combined procedure because she is also an infertile patient. So I just wanted to see how exactly put the scope done. Last. Okay, so this was a plethora of fibroids, so decided to open up the myometrium, the endometrium, and remove all of these fibroids, laparoscopically pick them up one by one, and then do a laparoscopic myomectomy for a submucosal myoma. So you can see now I have gone into the endometrial cavity and I am picking up all this myoma one after the other. So here the basic advantage is you will not require any energy source. You will just introduce your myoma screw onto the myoma because it is doing hysteroscope through laparoscope. So you go into the endometrial cavity, pick the myoma and remove one after the other. No energy source is needed. It is just like toothpick effect, pick them up. So the basalis is also not damaged. So there were real huge ones. The large 3 centimeter one was calcified. In such case, you can just core the myoma with a harmonic scalpel. That is, you have to score only on the myoma, not on the endometrium. So in that way, you will not damage the endometrium. When you have 15 submucosal myomas, you won't have a charred endometrium, you won't have an Asherman syndrome, you will have a pink endometrium and she will conceive. So, and also you can suture the myometrium above the endometrium. So all the 15 myomas were removed. So the complications, of course, I have mentioned all the complications as I was presenting these cases. So to prevent complications, proper workup, and also to prevent post-operative adhesions. So you can go either with hormonal therapies, estrogens and progesterone. 3 weeks of estrogens followed by progesterone is a good bet when it is an infertile patient because it helps us to regenerate the endometrium and she is ready for fertility treatment. So these are the advantages of the hormonal preparations of the endometrium post surgery, and of course the fluid overload and all those things which I have already been talking during my surgical procedures, and of course bleeding and perforations which we have to tackle. So final consideration, of course, hysteroscopic myomectomy is a very difficult and complex surgery among all the hysteroscopic procedures, but it has a very good outcome if done in the right manner. So safety is mainly based on the proper preoperative evaluation and a proper surgical technique. So thank you so much for the opportunity and the patient listening.
It was an elaborate discussion on myomectomy by hysteroscope. One last question: what is the largest size of fibroid which you did through hysteroscopic myomectomy in single sitting? Yeah, single sitting I've done only up to 4 centimeters. Beyond 4 centimeters, I feel it is better to combine it with laparoscope. I have a very nice video where I have also done that almost 6 centimeter. It was a single submucosal myoma. I have just opened the entire myometrium, opened the endometrium, picked up the myoma, and it was like a laparoscopic myomectomy. And finally sutured only the myometrium. We don't have to even suture the endometrium because the endometrium regenerates on its own. And you showed the last slide about tissue retrieval system.
Yeah.
It seems to be very fast.
Yeah.
You have tried it,
It is.
or is it a-
I'm having. It is. I have the True Clear. It is a very good one.
Thank you,
Medtronics.
ma'am. Thank you very
Thank
much.
Rather an elaborate and an exclusive session that shows your passion towards the surgery, hysteroscopy and laparoscopy. Hope all of us really enjoyed. Thank you, ma'am.